All right, let's dive right into this. Today, we are decoding evaluation and management speed coding, so you can completely eliminate those tricky distractors on your AAPC CPC exam. This explainer is going to give you a solid framework to identify the right code, save precious minutes, and honestly, just crush the section. So let's see exactly how this strategy works. Here is our agenda for today's explainer. First, the EM speed coding blueprint. Second, the three-step rapid elimination strategy. Third, MDM decision matrix shortcuts. Fourth, high-yield exam trap scenarios. And finally, number 5, final exam day mindset.
Let's kick things off with Section 1, the EM Speed Coding Blueprint.
Listen up, coders, because this is a major shift for your practice tests. Thanks to the 2023 guideline updates, you can officially stop wasting exam time calculating history and exam elements. They only support medical necessity now. Instead, your code selection for outpatient services is based entirely on either medical decision-making or the total time spent on the date of service. You should also keep in mind that observation and inpatient codes are now merged, and those old prolonged service codes, they're completely gone. So, your very first major shortcut is instantly recognizing which coding path you're on. When a scenario demands a time-based code, you're going to want to look for keywords showing the provider spent extensive time counseling, coordinating care, or reviewing records. On the flip side, you'll use the MDM-based method when the encounter involves complex diagnostic decisions, a huge volume of data to review, or moderate to high risk to the patient. Oh, and here's a pro tip. If an exam question gives you both the total time and the MDM details, always select the higher supported level. Okay, moving right along to Section 2, the three-step rapid elimination strategy. This three-step framework is literally your secret weapon for the exam. Step 1, immediately identify the setting, like office, ED, or inpatient, and check the patient's status, so new versus established. Step 2, determine your decision basis. Are we looking at total time or MDM? And then Step 3, the most fun part, scan those multiple choice options and ruthlessly eliminate the out-of-range codes. You want to systematically cross off the wrong distractors before you even spend time reading the remaining options closely. Step 1 relies heavily on this CPT decision tree for office visits. You need to ask yourself one defining question. Has the patient received any professional services from this physician or another physician of the exact same specialty and subspecialty in the same group practice within the past 3 years? If no, they're a new patient. If yes, they're established. So if a scenario says a patient was seen 2 years ago by the exact same subspecialist, you can instantly cross out all new patient code options. That right there is going to save you a massive amount of reading time. All right, Section 3, MDM Decision Matrix Shortcuts. I know the official AMA Levels of Medical Decision-Making table looks like a giant wall of text, but don't panic. Under time pressure, the absolute most critical rule to remember is that you do not need to meet all 3 columns to finalize a level. You only need to meet or exceed 2 out of the 3 elements. That's problems, data, and risk to lock in your overall MDM level. To process questions way faster, just memorize this stripped-down shortcut matrix. For a low MDM, just scan for 2 minor problems or 1 stable chronic illness paired with low risk. For moderate, look for 1 chronic illness with an exacerbation or 2 stable chronic illnesses with moderate risk. And for a high MDM, your keywords are going to be acute illness threatening life, extensive data, and high risk. Remember, just match 2 of those criteria and your level is secured. Next up is Section 4, high-yield exam trap scenarios. Let's put this into practice. The exam is going to throw some specific traps your way, so let's look at a few. Imagine a patient visits for a routine hypertension follow-up, a standard EM service. But during that exact same visit, the provider also does a wart removal. How do you handle a problem-oriented visit happening on the same day as a minor procedure? Well, the test makers will definitely try to trick you into bundling them. Boom! The correct approach here absolutely requires modifier 25. You have to append it to the E&M code, like a 99213, and bill it right alongside the procedure code. Modifier 25 proves to the payer that the E&M service was significant and, most importantly, separately identifiable from the wart removal. So whenever a distinct E&M and a minor procedure happen on the same day, immediately start hunting the answers for the option that includes modifier 25. Let's look at trap number 2, which tests your emergency department knowledge. A 45-year-old comes into the ED with chest pain. An ECG is done, it's normal, the patient is observed in the ED for 4 hours, and then discharged. Do you see the trap here? It's the 4 hours of time mentioned. That right there is a classic distractor. Here is the hack. In the ED setting, time is completely irrelevant for selecting regular ED levels. Those services are provided on a variable intensity basis, so you just ignore those 4 hours entirely and base your code on the MDM. Because of the multiple tests and moderate risk in that scenario, you're looking at a 99284 for moderate MDM. Also, a huge time saver for the ED. Immediately eliminate any answer choices based on new or established patient status, because the ED makes zero distinction between the two. Okay, trap number 3. This explores when a really severe ED visit actually crosses the line into critical care. Here we have an ED patient with sepsis who is in shock, and the physician clearly documents 90 minutes of direct critical care management. Watch out, because they will absolutely throw high-level ED codes at you as distractors for this one. The big takeaway here is that because the condition is demonstrably life-threatening and specific time spent in direct management is documented, you completely abandon those standard ED codes. You jump straight to the critical care codes. You'd report 99291 for the first 74 minutes, and then the add-on code 99292 for the additional time. Critical care requires both that high clinical intensity of a life-threatening illness plus crossing those specific time thresholds. Finally, let's wrap up with Section 5, Final Exam Day Mindset and Time Management. Exam day is all about pacing, so here are a few rapid-fire best practices. Always make sure the ICD-10 diagnosis intensity actually matches the E&M level. Like, a mild cold is never going to justify a level 5 visit, right? Also, pace yourself. When you hit a massive wall of text that's highly complex, just flag it and move on so you can grab the easy points first. Above all, trust your 3-step rapid elimination process. Don't second-guess yourself once you've proven an answer is an out-of-range distractor. I want to leave you with a golden rule of coding compliance that applies perfectly to board exams. If the diagnosis and plan don't justify the E&M level, downcode for compliance. Medical necessity is the overarching ultimate criterion. Even if a provider checked every single box on their template, if the documentation just feels light, the correct answer is always going to be the lower code. If you can master this elimination game, you will absolutely decode the matrix of the E&M section. Yes, the distractors are there by design, but with this blueprint, you're going to see right through them. Now that you're armed with these specific MDM shortcuts and you know how to dodge those trap scenarios, you're going to breeze through your next practice exam. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.